I'm going to go ahead and share my screen and arrange my windows so that I can see everything. And one of the things just to mention for the workshop, I think it was noted on the slide, it's a big group of people, which is so exciting. I'm so glad to see everybody, but it means that we may not be able to address questions as they come up. So if there are questions that you have, please type them into the chat, and closer to the end of our time together, Emily will, take a look at those questions, and we'll try to go through as many of them as we can, as we have time for at the end. But just in order to make it so that, people aren't talking over each other, or there's too much chatter going on, we'll have to save most of those questions until the end. We'll take a couple of 5-minute breaks throughout our time together so that we're keeping the blood moving and, not sitting for too long. And also closer to the end of the workshop, we'll do a little bit of an interactive kind of exercise where I'll ask people to participate a little bit, and we'll talk about the idea of just using the raise your hand function at that point to interact and participate. So anyway, thank you all so much for coming. Again, it's great to see so many people interested in anxiety disorders. My name, as Emily mentioned, is Dr. Sandy Capaldi. I'm actually the Associate Director at the Center for the Treatment and Study of Anxiety at University of Pennsylvania. And we're a clinic that specializes in treating just anxiety and related disorders. The best part, I think, of specializing in treating anxiety disorders is while anxiety disorders can be extremely severe and debilitating, they're also very amenable to treatment. So that makes the work that we're doing really very rewarding, because we see people who are suffering so greatly when they first come to us. And throughout the course of treatment, we see their lives change relatively quickly. And we see this happen so frequently. It's really, great positive reinforcement for us as therapists to be able to see those changes, those strides that people make. So it's really, something that I've been passionate about for years. And again, what we specialize in at the CTSA. Now, today, we're going to talk about the basics of anxiety and related disorders. We're going to have another workshop similar to this, 3 hours in length, where we're talking about treatment specifically. But today, we're going to be just talking about the basics. Okay, we're going to discuss some terminology related to anxiety. We're going to learn how to distinguish anxiety from anxiety disorders. We'll take a look at some of the prevalence of anxiety disorders, along with things like comorbidities, components of anxiety disorders, and the cycle of anxiety that actually helps to maintain it. We'll spend some time discussing each of the specific anxiety and related disorders, and we'll take a look at some video of some examples of people living with anxiety. Before what we'll briefly touch at the end on treatment for anxiety disorders, just to kind of, get you interested maybe in that next workshop that we're going to have. And before we do that, though, we'll do, like I mentioned, that little interactive exercise where we're going to look at different case studies to see if we can identify the anxiety disorder that the case study is representing. Okay? So the first thing for us to know about anxiety is that it's not all bad. Anxiety is actually a very common and essential process of our daily lives. If we think about anxiety from an evolutionary perspective, it's extremely important because we typically experience anxiety when we're faced with a threat. So thousands of years ago, if we encountered a lion, it would trigger our alarm system, right? Which would in turn cause us to protect ourselves from the danger in whatever way necessary. So anxiety can kind of orient us toward anticipating danger. It can motivate us to act in order to avoid events that might cause us bodily harm or even psychological distress. And it prepares our body and our mind for taking some sort of action. Now, even in everyday modern situations, right, most of us aren't facing lions on the daily, right? But even in everyday situations nowadays, some level of anxiety can be a good thing. The sound of a fire alarm while we're in a building, right? That can alert us to potential danger and motivate us to act accordingly, right? To get out of the building. Or anxiety about a big exam coming up may motivate us to study more. In fact, what we know is that a little bit of anxiety has been shown to help us to get things done, helps us to do our best and reach our goals, in addition to helping us to avoid danger like we were talking about. And if we think about it from the other side, a complete lack of anxiety could cause somebody to engage in potentially life-threatening and dangerous situations and not even be aware that they're dangerous. So as you can tell, I mean, that would not be a good thing either. So what is anxiety actually? There are lots of different definitions, but the most comprehensive is probably to say that anxiety is a state that's characterized by nervousness and a feeling of unease. Anxiety is typically focused on an upcoming event or other situation whose outcome is uncertain. It's often accompanied by physical symptoms of tension, changes in heart rate or breathing or muscle tension. And remember, just like we discussed a moment ago, it's not necessarily bad. So part of the definition of anxiety is that it can be a motivating experience that can be extraordinarily helpful in small bits, but it can be really impairing in larger doses. Now, a term that's often used kind of in conjunction with, or sometimes even interchangeably with anxiety is stress. And from the outside looking in, it can be difficult to spot the differences between stress and anxiety. Both of them can lead to, sleepless nights, exhaustion, worry, lack of focus, irritability, even physical symptoms like, rapid heart rate or muscle tension, headaches. All of these things can impact people experiencing stress as well as people experiencing anxiety. Stress, though, is your body's reaction to a trigger, and it's generally short-term. Like anxiety, it can also be positive or negative. So when you're stressed and you pull off that deadline that you thought was a lost cause, that can be a positive. But when it results in not being able to sleep, not being able to concentrate, not being able to do the things that you normally do, then it can be negative. Now, the best way to distinguish stress from anxiety is really the focus on the present. Stress is based in the here and now, while anxiety is more future focused. So, you experience stress when you have an awful morning, getting your kids up and off to school, let's say. Your oldest won't get up until the last minute. Your youngest maybe wet the bed overnight. The middle child keeps messing with the younger one and they're fighting with each other. You're trying to get breakfast together. You drop a whole gallon of milk in the kitchen while you're, doing that, and that goes all over the place. The bus is maybe running late, or maybe the kids have missed it, right? Nothing's going right. That's stress. That's stressful. Anxiety, right? And it's focused in the here and now. Anxiety is when you finally do get them off to school and you spend the rest of the morning and maybe even the most of the day and night worrying about it, lying awake in bed, worrying that you'll have the same type of morning tomorrow, that you haven't made that doctor's appointment yet. What if we do actually miss the bus? What are we going to do? right? So it's happening outside of the situation, and it's worried about what's going to come next. So you can see that the stress in this example was focused on the here and now of the situation, while anxiety was focused on the what if, what will happen in the future. Now, another term that comes up when we're thinking about anxiety is worry. We've mentioned this already as we've been talking about anxiety. Okay? It's a prominent component of anxiety. Worry is really a relatively uncontrollable sequence of negative emotional thoughts and images that are concerned with those potential future threats or danger. It's really critical in kind of the classification of anxiety disorders because some disorders will focus on certain things, certain kinds of worries, and some will focus on others. Now, to be fair, everyone worries now and then, right? So to be considered pathological or problematic worrying, it usually will differ in, not only the frequency, so how often it's occurring, but also the quality of the worry. So problematic or pathological worrying will often take the form of what if questions. And the answers to those questions are invariably negative and unrealistic. And again, feel uncontrollable. We can't stop worrying about them. So for example, if we are worried, what if I don't do well in this job interview, right? Many people may have that kind of a worry when they're faced with that situation of needing to get a new job. For someone who struggles with anxiety, who has this pathological kind of worrying, the answer to that question is always going to be negative, right? Well, it's going to be the end for me. Life is going to be over. It means I'll never get a job. Now, not only are those answers excessively negative, they're also pretty unrealistic, right? I mean, even if you don't do well in one particular interview, it doesn't mean that life is over or that, you'll never ever get a job at some point in the future, right? And so you can see how that the quality of that worrying might be different than non-pathological worrying, where we may be able to see like, well, even if I bomb this interview, I'll probably do okay in another interview. I mean, I'll get a job at some point. I'm not going to never have a job again, right? And so the thoughts are more realistic around it. Now, another term that frequently comes up when we're talking about anxiety is fear. So let's talk about fear for a second. Fear is really an immediate alarm reaction to danger. And again, like anxiety, it can also be adaptive. Fear activates our alarm system. It motivates us to escape danger, try to protect ourselves, or even to freeze. And remember that these kinds of reactions aren't specific to human beings, right? We see them in animals as well. And they're really our best defense against danger in any given situation. Now, you may have noticed that a lot of the way that we're defining fear here is a lot like anxiety. And so I think it's worth it to think about, what are the differences? So although they're really highly related, they're different from each other in a couple of ways. So first, fear is a response to a real danger, and again, directed at present threat, something that is happening in the moment right now. It's usually accompanied by escape or fighting or fleeing behaviors, right? It's accompanied by physiological arousal, right? The body, we're going to talk about that in a second, the body kind of getting ready to do those things. And the thoughts about the imminent threat that's right there in front of us. It's also highly biologically adaptive, right? It allows us to avoid these potential dangers. And thus, again, if we're thinking about this evolutionary perspective, allows our genetic line to continue because we survived the situation. Now, anxiety, as we've been talking about, is more future oriented, right? It corresponds more to a state of uncertainty or ambiguity, right? That is focused on what is going to happen. Now, that's often accompanied also by avoidant behaviors, right? And that tension and that thoughts about the future threat, right? Not the thing that's in front of us right now, but about the future. So while fear is a response to a present or imminent threat, anxiety occurs in anticipation of a future event. And it's easy to confuse the two because both involve cognitive kind of appraisals of threat or danger. Both are, adaptive, but the best way I think to distinguish and remember the distinction between the two is to remember that present focus, which is fear, versus the future focus, which is anxiety. Okay. Now, I said we were going to talk a little bit more about that physiological arousal that happens. And this is something that, many of us learn about in school. So it might be kind of a review or a refresher for you, but, or maybe you haven't heard of it yet. So the idea of the fight, flight, or freeze response. I've mentioned that it sort of evolved as a survival mechanism, right? It enables people and animals to react quickly to a life-threatening situation. Now, while that's adaptive in general, right, has kept our ancestors from being eaten by lions, unfortunately, we can also develop the same fight, flight, or freeze reaction to situations or stressors that aren't life-threatening. Now, this stress response begins in the brain, as we can see in this illustration here. Okay? When we see an oncoming car coming towards us, for example, our eyes, our ears are going to send information to the amygdala. Okay? That's the area of the brain that contributes to emotional processing. The amygdala is going to interpret those images and sounds. And when it perceives danger, it's going to instantly send a distress signal to the hypothalamus. Okay? Now, the hypothalamus is like the command center in the brain. It communicates with the rest of the body through the autonomic nervous system. The autonomic nervous system is responsible for kind of the involuntary bodily functions, breathing, blood pressure, heartbeat, right? The stuff that's happening all the time, but we don't have to think about it. Now, the amygdala sends that distress signal. Then the hypothalamus sends the signal to the body to begin pumping adrenaline into the blood system, which causes a number of physiological changes. The heart starts beating faster than normal. More blood is pumped to the muscles, your heart, to vital organs. Your pulse rate and your blood pressure go up. Your breathing becomes more rapid. Extra oxygen is sent to the brain to increase alertness. Your senses of sight and hearing and other senses become sharper, right? The adrenaline also triggers the release of blood sugar and fats that are stored temporarily in your body to be released, which flow into the bloodstream and then give you more energy. All of this is designed to prepare you to face this danger, right? Again, this lion, right? And they all happen so quickly that we aren't even aware of them. The wiring here is so efficient that the amygdala and the hypothalamus, they're starting this cascade of events even before the brain's visual centers have had a chance to even fully process what's happening, like before we're aware of it. That's why we see people who are able to jump out of the path of an oncoming car even before they think about what they're doing. Because the brain, these deeper parts of the brain have already analyzed the situation and reacted to it. So this entire process is focused on preservation of your life, whether it's to flee from the danger, to try to fight it off, to be perfectly still in the hopes of not being detected by a predator. It's all very efficient and very adaptive in most cases. Because as we've mentioned, when someone has an anxiety disorder, this system will get activated even when there is no real threat. And we'll talk a little bit too about how that happens today. So what are anxiety disorders? They differ from kind of normative fear or anxiety because they're excessive or they persist beyond what would be considered developmentally appropriate period. They're typically long-lasting, occurring for 6 months or more, right? So they last for a long time. And many anxiety disorders actually develop in childhood and tend to persist if they're not treated. As I mentioned, they often cause immense distress, often interfere with the person's ability to function. They all have this kind of idea of excessive anxiety and the presence of compensatory behaviors like avoidance or safety behaviors in common. But they differ, each anxiety disorder differs in the focus of the anxiety. Okay? So let's take a look at a short video clip to just hear some sound bites. Like I said, I want to bring this home to not just like what is the academic definitions of this stuff, but what is it like to live with these anxiety disorders? So we're going to hear, this is just a minute long or so, some sound bites from real people suffering with anxiety disorders.
You could look at me when I was having a panic attack and you would have no idea. I would never tell anybody if it was happening because I knew it would make people worried.
About 1 in 10 children and adults are struggling with an anxiety problem.
You get stuck. The worry, it takes over. You're prisoner to the worry.
I felt that I stuck out like a sore thumb.
I would literally feel ill.
I was so detached from so many situations. It caused me to come to believe that I was going crazy.
My whole body would just turn into a shaking mess.
People think they're having a heart attack, people think they're dying, people think they're going crazy.
The scariest part about it was I felt like I was almost in a sense of like unreality.
The best evidence we have now is that the sooner you do something about the problem, the better.
It's daunting but freeing to realize that I had these huge walls up around me, but that I actually had all the power to break them down.
Don't give up on yourself. Give yourself a chance. There's hope. There's hope out there.
So this short clip gives us a little bit of insight into what living with an anxiety disorder is like. Now I'm going to show a few videos, again, short clips throughout to kind of help us see these disorders from that personal perspective. But all in all, the good news is, as I said, anxiety disorders are highly treatable, right? So there is hope. Bad news, though, I guess, is that they are very common. Okay, so let's look at the prevalence rates of anxiety disorders. In the US, we've got information about how frequently anxiety disorders are diagnosed. Okay? Remember that we may not know how frequently people experience them because they may not be seeking treatment or may not be seeking treatment in the same places. We'll see some of the anxiety disorders that we talk about today that many people will go to medical doctors instead of mental health professionals. And so they may not get counted in these counts, these prevalences. Right? Now, anxiety disorders have the highest overall prevalence rates among all of the psychiatric disorders. They have a 12-month rate of 18.1%, which means that at any point in the last year, 18.1% of people will report having an anxiety disorder, and a lifetime rate of 28.8%. So almost 30% of people at some point in their lives have an anxiety disorder. In any given year, we can expect that over 40 million people in the United States are impacted by anxiety disorders. We do see that prevalence is impacted by racial and ethnic status as well as gender. We see higher rates of anxiety disorders in general diagnosed in Caucasians than in African American or Hispanic Americans. We see the lowest rates of anxiety disorders diagnosed in Asian Americans. There is variability, that's anxiety disorders in general. There is some variability depending on which anxiety disorder we're talking about. Like, for example, with PTSD, we see higher rates of diagnosis of PTSD in African Americans than in any of the other racial or ethnic groups. And so it can be specific based on disorder as well. But if we look at anxiety disorders as a whole, that's the breakdown that we see. We also see higher rates of diagnosis of anxiety disorders in women as opposed to men. So women are almost 2 times as likely to have an anxiety disorder diagnosis at some point in their lives than men are. We do see a lot of variability internationally. So there's estimate of 0.9% in China of anxiety disorders, up to 28.3% in Afghanistan in some of these studies. On average, the global current prevalence for anxiety disorders is about 7.3%. So that suggests, if we do the math, that about 1 in 14 people around the world at any given time is struggling with an anxiety disorder, and that 1 in 9 will actually experience an anxiety disorder in any given year. So very prevalent. This is something, and I'm sure, I'm preaching to the choir a bit. If you're here, you're interested in anxiety disorders and probably know how prevalent they are, but definitely there is a lot of people experiencing this. And what that translates then to is a high cost. So anxiety disorders in the United States cost over $46 billion per year in increased medical expenses, lost productivity, mental health costs, right? In fact, anxiety disorders alone account for over 31% of all of the mental health costs in the US each year. Now, there's also the personal toll it takes on individuals, right? Folks with anxiety disorders tend to have higher rates of divorce and marital dissatisfaction, more financial difficulties, lower educational achievement, and more limits on what they can do or feel like they can do for work, less choice in the job market. Now, in addition to those burdens, we also see that comorbidity, or having another diagnosed mental health disorder on top of the anxiety disorder, is really high. So among adults ages 15 to 54, we know that anxiety disorders are the most common mental health disorders. Okay? About 50% of individuals who experience an anxiety disorder also meet criteria for another type of anxiety disorder as well. We also see a high occurrence of mood disorders alongside anxiety disorders. For example, major depressive disorder occurs in about half of the cases of anxiety over the course of the person's life. GAD, or generalized anxiety disorder, and panic also show really high levels of comorbidity with other anxiety disorders, meaning that you're very likely to carry at least 2 diagnoses of anxiety disorders if you suffer with GAD or with panic disorder. So for all of these reasons, it's extremely important for us to be able to recognize anxiety disorders and be able to know, how to treat them. So let's take a look. In order to do that, it's good for us to first learn to recognize the components of anxiety, which are threefold. We've got physiological components, cognitive components, and behavioral components. And we're going to talk about each of those separately. So physiological components of anxiety are those physical symptoms or reactions that we have in response to feeling anxious. So they can include things like muscle tension, often that's felt in like the shoulders, the neck, the back, heart palpitations, hyperventilation, gastrointestinal discomfort, sweating or chills, a feeling of dry mouth, shaking or trembling, blushing, going pale. All of these and more, right? This is just a sampling, are the body's reactions to anxiety. Sometimes even like in panic disorder, these physical sensations of anxiety even begin to become feared because they're associated with these other components of anxiety. So the next component is the cognitive component of anxiety. This is where we see unhelpful patterns of thinking emerge. So anxiety is often associated with catastrophizing or thinking that the absolute worst possible outcome is going to occur in any given situation. We also see loads of what if questions, again, with a focus on some sort of dreaded, terrible outcome. What if I completely freeze on stage? What if I have cancer, right? Thoughts like that. We find that these patterns of thinking become obsessive in that it's difficult to stop having them or to stop worrying about what might happen. Another example is thinking about and being afraid of losing control, right? Being afraid that we'll go crazy if we keep thinking this way, or if our feared outcomes do actually come true. So these cognitive components of anxiety, coupled with the physiological components that we just talked about, often motivate the behavioral component. Behavioral components can include that fight, flight, or freeze reaction that we've talked about, but also include other compensatory behaviors like avoidance or safety behaviors. So we'll tend to avoid situations that we think may make us anxious, or we'll only approach them in very specific ways while utilizing something that makes us feel safer. So again, an example with panic disorder. Those who suffer with panic disorder often carry around a prescription of benzodiazepines, just in case. Now, this is a safety behavior. It makes them feel safer to have the medication on hand, and is often the only way they'll agree to go places or do things is if they have their medication. Or let's take, an individual with post-traumatic stress disorder, PTSD, who might entirely avoid situations that now feel uncontrollable to them, like being in a crowd where it's noisy and there's too many people and things to try to watch in order to feel safe. And so they'll just completely avoid going into those kinds of situations. Now, when we put these components together, we can see how they interact with one another. Let's take an example of a person with social anxiety disorder, right? Who's invited to hang out with some new friends, let's say. His first thoughts might be, I will be so awkward. I won't know what to say. What if they think I'm stupid, right? So that's these cognitive components here. Those thoughts might trigger the physical symptoms. Maybe he starts to sweat, maybe his heart is racing. And as those thoughts and those physical symptoms continue to intensify, he can't see how he could possibly do this alone. And thinks, I'd be much more comfortable if my best friend, who doesn't know this other group of friends, came along, right? So he asks, this new group of friends if it's cool if he brings his friend with him. That's a safety behavior, right? They say, okay, and that's the only way that he'll go and hang out with this group. Or let's take another example with panic disorder. With panic disorder, it often starts in the physiological. So a person begins to feel shaky, notices their heart's beating a mile a minute, start to feel like they're having trouble breathing. And then they think, right, the cognitive component, oh no, I'm going to freak out here at the mall in front of everybody. Everybody's going to see me go crazy. They're all going to laugh at me. So they very quickly spot a bathroom, go inside and close the door. That's avoidance, right? While they're in that bathroom stall, they're searching through their purse, looking for that bottle of Xanax. That's that safety behavior. So you can see how each of these components can interact and affect each other. The cognitions can influence the physical sensations as well as the behaviors. The physical sensations can impact the thoughts and the behaviors. The behaviors can influence the thinking and the physical reactions, right? They're all interconnected. Okay? And that's how that cycle of anxiety goes, where it can start in any one of these areas and continue on from there. Okay? And so the person gets stuck in this cycle that is very difficult to get out of. Okay, so before we move on to talking about specific anxiety disorders, let us take a 5-minute break. Okay, like I said, don't want to keep people sitting for too long, so we're going to resume at 1:45. Okay, it's 1:40 now, and we'll start to talk about specific anxiety disorders then. Okay, so take your 5 minutes, and we will see you soon. All right, everyone, it is 1:45, so let's come back in from our break. I hope you were able to do something to take care of yourself, whether it's to pop up and take a little walk, get a drink, make a bathroom stop, whatever it is you needed to do. So we're going to now move into talking about some of these specific anxiety disorders. So now that we know about what anxiety is and how it works, we'll take a look at these specific anxiety and related disorders. So I say related disorders because there are some disorders that were previously previously categorized as anxiety disorders like OCD and PTSD, but who were given their own categories. Now, since the cycle of anxiety that we talked about works the same for them, I'm going to include them in our discussion today. But for the purists in the group, this slide represents the official anxiety disorder. So this is it: separation anxiety, selective mutism, specific phobia, social anxiety disorder, panic disorder, agoraphobia, and generalized anxiety disorder. Now, as I mentioned, OCD was given its own category more recently. And so these are the obsessive, compulsive, and related disorders. We're only going to talk in more detail about the two that are highlighted here with the orange glow, OCD and hoarding, because those fit that cycle of anxiety that we talked about a minute ago. Whereas body dysmorphic disorder, trichotillomania, and excoriation work a little bit differently. Okay, so we're not going to be talking about those today. And then we have trauma and stressor related disorders, which are also now their own category. And the three disorders that are related to anxiety here are PTSD, acute stress, and adjustment disorder. Now, there are two other anxiety disorders that I wanted to mention, and I hope we'll have time to talk about them. These are somatic symptom disorder and illness anxiety disorder. So again, they're not included in the umbrella of anxiety disorders anymore. They're in their own category of somatic symptom and related disorders. But since they can be conceptualized using that same cycle of anxiety model, we'll talk about those today too, hopefully. I hope we have time for those, okay? So let's start with separation anxiety disorder. This is, these first two are disorders that separation anxiety and selective mutism are disorders that are most likely to begin earlier in life, okay? Now, the essential feature of separation anxiety disorder is basically excessive fear or anxiety related to separating from home or from attachment figures, caregivers or parents, right? Individuals that experience separation anxiety disorder will have symptoms that meet at least three of the criteria listed, okay? So recurrent excessive distress when they're separating from home or from their caregivers, worry about the well-being or potential death of a caregiver if they're not close to them, okay? Needing to know the whereabouts of their caregivers, a desire to stay in touch with them, worrying about kind of bad things happening to themselves, right? Getting lost, being kidnapped, having an accident, something that would keep them from ever being reunited with their attachment figure. These kids, and again, it's often kids, will be reluctant or refuse to go out by themselves because of these separation fears. They may even have difficulty being by themselves at home. They may be very clingy, kind of stay close to or shadow the parent around the house, or maybe even require someone to be with them if they go into another room of the house. They may be really reluctant or refuse to go to sleep on their own, right? Or especially to sleep away from home. Kids with separation anxiety disorder often have difficulty at bedtime. They may insist that someone stay with them until they fall asleep. even during the night, they may make their way to their parents' bed or to, a sibling's bed or something so that they're not alone. They may be, refusing to do things that they don't have to do, like go to camp or sleep at a friend's house or even to go on errands. A lot of times we see that kids with separation anxiety disorder will have repeated nightmares where the content of the nightmare is often an expression of their anxiety. So, there's a fire in the house, which, kills members of the family, or some other kind of catastrophe, again, that doesn't allow them to be reunited with their caregiver. Often these kids will have physical symptoms like headaches or stomach aches, right? Vomiting, especially when they are anticipating that there's going to be a separation or there is an actual separation. They can experience some of those other physiological symptoms like heart palpitations and dizziness, feeling faint, right? Those kinds of things are a little bit more common in like adolescents and adults, but definitely kids can experience that as well. Now, some of the things that we often see, kind of associated features of separation anxiety disorder, we see that kids who are separated from their caregiver, and again, I don't mean this in like a foster care sense, or I mean like because they went to school for 6 hours that day, right? Or because mom or dad went to work, right? So that's the kind of separation we're talking about here. They will, often socially withdraw from others. They'll have difficulty concentrating when they're separated from their attachment figures. Depending on age, some of these kids may have other sort of seemingly unrelated fears of animals or monsters, fears of the dark, again, fears of being kidnapped, car accidents, right? Situations that may be perceived as kind of potentially dangerous to, family members or to themselves. People with separation anxiety are often homesick if they're away from home, right? And sometimes uncomfortable to the point of like being just absolutely miserable. As you can probably hear, this may lead to school refusal, right? Not wanting to leave the home or leave your caregiver. And, that not going to school or, missing a lot of school is going to lead to academic kind of difficulties and social isolation. Sometimes kids will get very angry or, even show aggression towards people who are trying to, kind of force the separation. With littler kids, we see sometimes or hear about some kind of unusual perceptual experiences. Again, these are manifestations of the fear. So we'll hear kids talking about like at night, they see people peering into their room, or, different shadows look like, frightening monsters, like reaching for them. So things like that, again, that are, kind of around this idea of something happening to them or to their loved ones. Now, separation anxiety, remember, is a normal part of development for all of us. When babies are, young, especially around a year old or so, they start to suffer from this kind of stranger anxiety where, if they don't know you, they don't want any parts of you, right? And they cling to mom or dad or to, siblings that, that they do know. But this is something that persists, right? This persists into, preschool age and school age children. And that's usually where the onset is around that preschool age, where we see separation anxiety disorder starting to be diagnosed and starting to develop. More rarely, it will occur in adolescence, but usually we're seeing it happening first in littler kids. And there are typically kind of periods of like exacerbation and remission, where sometimes it will be much worse and sometimes it will be much better. Again, this can persist through adulthood. But what we find is that for most people, separation anxiety will sort of resolve over the course of the lifetime. If we do have an adult who has separation anxiety disorder, they often, don't recall the onset. Like, it's just that's always how they've been. So they might recall the symptoms or, what was occurring for them, but not a particular event that, caused it or triggered it. When we think about kind of some culture-related diagnostic issues, there are, cultural variations in the degree to which it's considered desirable to be separate from kids, right? In many cultures, kids are with their caregivers 24/7 until they're much older. Or, in some cultures, it's much more acceptable to, live at home with parents until an older age, or vice versa. In some cultures, it's expected that you're going to separate from the parental home earlier. And so it's important to kind of, think about this when we're thinking about separation anxiety, about what are the cultural values of the family when it comes to this, right? And what's the value placed on independence versus interdependence at any given age. Okay. So I have, again, another little clip. This one isn't my favorite, but I wanted to be able to show something about social anxiety, separation anxiety. And the reason it's not my favorite is because this is not a real person. So this is just an actress and an actor. But I think that it does a decent job of kind of letting us in on what the thinking is like for a kid who's experiencing separation anxiety. So let me show this. This is only 4 or 5 minutes.
Maria, come on in.
Where's my mom?
Well, she's in the waiting room. She's not going to go anywhere. Come sit down. Are you pretty worried about your mom?
It's okay.
Okay. What did your mom tell you why you're coming here today? Well, she said you're missing a lot of school.
I don't like the school. The kids are mean.
What do they do that's mean?
They call me names like crybaby, and they say I should be wearing a diaper.
And what do you do when they call you names?
I hide somewhere, like behind a tree, in the playground, or in the bathroom.
Oh, the school got really scared last week because they couldn't find you. Do you remember that?
I told the nurse I had a fever, but she said I didn't. And then Jose saw me coming out of the nurse's office, and he said, "Oh, look at crybaby Maria. Did you go get your diaper changed?" So instead of going back to class, I hid behind the stage in the cafeteria.
Did you hear people calling out for you?
Yeah, but I was afraid I would get in trouble.
Yeah. Why do the kids make fun of you by talking about diapers?
I went to the bathroom myself once.
Yeah. How did that happen?
My mom had said that she was going to pick me up for a dentist appointment, so I was waiting in the office area. She was late, and I got really scared that she wasn't going to show up. I had to go, but I didn't want to miss her. I keep holding it, but I couldn't.
You must have felt really embarrassed.
Yes, I never want to go back to that school again.
Your mom also said you don't like to get on the bus. Do kids make fun of you there?
Not so much, but I know that they're thinking about it.
Yeah. Well, it seems that you worry a lot about your mom. Were you afraid that she wasn't going to pick you up?
I worry that she got lost or was in a car accident.
So you're worrying about something bad happening about her. Yeah. And has anything bad happened to her in the past? Why do you think you worry about that so much?
I don't know. I just do.
Yeah. And how long have you been worrying about your mom like this?
When school started.
And do you worry every day?
Yes.
Yeah. And does the feeling last for a little while or for the whole day?
Whenever I'm away from my mom.
Okay. Well, you mentioned that you worried about her being in a car accident. Do you worry about other bad stuff happening to her?
We had a program on stranger danger, and after that, I don't want to wait for the bus because I thought I might get kidnapped.
And how often do you miss school because you're worried about your mom? Is it once a week or once a month?
Like twice a week.
And are you falling behind in your grades?
I'm failing reading and science.
And how were you doing in your grades last year?
I had straight A's.
Yeah. And when you do stay in school, can you do the work?
No, I can't pay attention to the teacher because I get all mixed up. I don't remember what she's saying, and I keep forgetting to turn in my papers, and I lost the science report I did.
Do you get out of your seat, or do you wiggle around in your seat?
I don't get out of my seat, but my leg shakes like this, and the teacher gets mad at me because I'm tapping my pencil.
Okay. Well, let me ask you some other questions. Do you ever get nightmares about bad stuff happening to your family?
I had a dream that they got killed in a fire. I woke up screaming.
And do you ever hear voices talking to you, things that other people can't hear?
I was in bed and I heard a voice from the closet say, "We're coming for you."
And how often have you heard that?
Just once.
And do you ever hear anything like that during the day?
No.
Okay. Well, who lives at your house with you?
My mom, my brother Jesse, and our cat.
Where's your dad?
I don't know. I haven't seen him in a long time.
How long?
Since I was 8. I really miss him.
Let's talk about that.
Well, I was at the RV and we had a drive, so I was really nauseous. And then we were talking.
So you can see in this example, you can see in this example that she's talking about, all of these symptoms, right, that we just talked about, right? The, nightmares, the not wanting to be away from mom, the worrying that something's happening to her. Okay. So it's, like I said, it's an actress and an actor and, is a little bit contrived. But I think is nice to kind of hear, sort of how a kid would talk about this too. Okay. So we've got a lot of anxiety disorders to get through. So let's turn our focus next to selective mutism. So this is something that's actually fairly rare. We only see it in, like 1% of kids, but selective mutism is where, a kid will, during social interactions, either won't initiate speech or won't respond to others. Okay? So it's this kind of lack of speech. It can occur in social interactions with children or adults. Okay? Usually kids with selective mutism will speak in their home, in the presence of like immediate family members or one single family member, but won't speak, even in front of close friends or, kind of second degree relatives like grandparents or cousins. This is often linked with a lot of social anxiety, although, these are usually younger kids and they're not really able to verbalize the content of, the worries about social anxiety. So these kids will often, refuse to speak at school and have, difficulties then, with academic achievement. Teachers find it difficult to assess what they've learned, right? Like because they won't read out loud or something like that. It also interferes with, kind of the social communication, right? Sometimes, these kids will develop non-spoken or kind of non-verbal ways of communicating. But still, you can imagine that doesn't quite do the job in communicating all of their needs. They might be really, much more eager or willing to, do things that, don't require speech, like drawing or, if there's a school play, like a nonverbal part, right? Because of this. I'm thinking right now of, I have an 18-month-old who's kind of, he says a few words here and there, but it's difficult for him to communicate, right? Because he's little, he just hasn't learned yet how to speak. And one of the things that he will do is when we guess at the things that he wants, he'll shake his head no, right? Nonverbal, telling us, no, we got it wrong. Or if we get it right, we're lucky enough to get he claps and he congratulates us for guessing it right. So those are, those kinds of like nonverbals can go a long way in communicating needs, but obviously it's much more efficient to be able to speak, right? So some of the associated features with selective mutism, these kids are often excessively shy. They're often afraid of social embarrassment. They're often very socially isolated and withdrawn. They might be more clingy to their caregivers. And sometimes we'll see even a little bit more oppositional behavior in kids with selective mutism. Remember, these kids generally have normal language skills, right? Although in some cases we'll see that there is an associated communication disorder, but that's not, again, that's the in most cases that's not what's happening here. Even if a kid has some other kind of communication disorder, usually anxiety is also present around the idea of giving, of speaking with others. In most cases, kids in clinical settings who have selective mutism are given another diagnosis, most commonly, like I said, social anxiety disorder. We see that this is most frequently developing before the age of 5, but it won't often come to, sort of clinical attention until the child enters school. Right. So whether it's preschool or kindergarten, where, there's an increase in demand for, talking and social interaction and performing things. The persistence of selective mutism is variable. A lot of clinical reports suggest that, many kids outgrow it. But the sort of the long-term course of selective mutism is kind of unknown at this point. Again, it's a very low base rate disorder, and so that often makes it harder to do studies because there's just not as many people to choose from. In cases where we see both selective mutism and social anxiety disorder, as I said, we'll often see that the selective mutism will be outgrown, but the symptoms of the social anxiety disorder will remain. In terms of cultural related diagnostic issues, sometimes we will see communication difficulties or refusal in kids who come from families that aren't speaking English at home. And we have to be careful about assessing for, is that the case? Are they just, sort of not confident enough in English or in the new language? Or is it associated with this anxiety and this social anxiety? So it could be, one or both of those things. Okay. Our next anxiety disorder is specific phobia. Now, specific phobias are very, very common. And, the sort of key feature of specific phobia is a fear or an anxiety about a particular situation or object, and just that particular situation or object. Although, many people with specific phobias will have these specific fears of objects or situations from more than one category, right? Because they're categorized. For a diagnosis of specific phobia, the person's response has to be different than kind of a normal fear that many people would experience, right? So we've got a picture here of a spider, right? Many people do not like spiders. And that's kind of a normative thing, or snakes, right? It's kind of a normative thing. To meet the criteria for a diagnosis of specific phobia, the anxiety has to be really intense and really severe. All right. And usually this fear kind of varies depending on, proximity of the phobic object, right? The spider, let's say, or whether it's actually they're in the presence of it or not. Sometimes the fear or anxiety becomes so severe that it's can result in a panic attack. When we see individuals who are experiencing specific phobia, we'll see that not only do they have this anxiety when they encounter the feared object, but also that they will actively avoid situations where they think that might come up. Or if they're unable to avoid it, they will, kind of go out of their way to do something, again, a safety behavior that makes them feel safe. So for example, someone who is afraid of going in tunnels, right? Sometimes when you're driving places, you have to go through a tunnel, will, drive 50 miles out of the way to go over a bridge instead, right? Or sometimes vice versa. Sometimes there are people who are afraid of bridges who will go 50 miles out of their way to go through a tunnel to get across a body of water. Or if someone's afraid of spiders, it'll generalize to like they won't even go into a dark room because they don't know if a spider might be there, right? Or sometimes people will structure their lives around this, right? They may have, several job offers in different places, and they will choose one based on where, the particular thing that they're afraid of is less common. Right. So a place that has less bridges, or a place that, has less spiders, and really kind of base their life around it. So often these kind of avoidance behaviors are, pretty obvious, like someone who's afraid of blood, refusing to go to the doctor. But sometimes they can be less obvious, like if someone's afraid of snakes, and will even refuse to look at pictures of snakes, right? And that doesn't come up very often, and so it may be a little bit less obvious for us. Many people with specific phobias have suffered with these fears for years, and as I said, sort of will structure their lives around it. In ways that aren't so obvious until you start asking the questions about why they made certain decisions, or what kinds of things they do to ensure that they don't come into contact with these feared objects. We again kind of thinking a little bit about sort of culture related issues, or, different circumstances that people may find themselves in. We always should be thinking about, when we're asking questions around this, what is the norm for, the people in your culture? What does your culture tell you about this? Because some of the things that people may be afraid of may be culturally normative, and we have to take that into account as well. I mentioned that the categories of feared objects, they're broken down into 4 different categories. So we've got things in the natural environment. These could be heights, storms, water, right? Thunder, lots of different things. We've got animal phobias, right? Spiders and snakes are always big among them. But, we could also have people who are afraid of dogs, who are afraid of horses, who are afraid of lizards, right? We have the kind of blood injection injury or medical treatment category, where people are afraid often of needles or invasive medical procedures. Again, afraid of blood, afraid of going to the dentist. Okay. And then the last category is the situational. So airplanes, elevators, enclosed places, right? All of these kinds of things. And then we also, it's not depicted here, but we can have, we have an other category. So sometimes we'll have people whose fears don't fit into one of these nicely. So people who are afraid of choking, people who are afraid of vomiting, right? Sometimes we'll see kids who have a phobia to like characters in costumes, right? Or clowns. So those are the kinds of things that don't necessarily fit into these 4 categories, but are included in this definition. When although we see that people who have phobias to those situations and environmental and animal stuff, when they experience, when they come into contact with the feared object, they will often have that arousal, right? That physiological arousal. But an interesting difference for those with that blood injection injury phobia is that often for them, they'll kind of experience the opposite. They'll have a vasovagal response where they might faint or come close to fainting because there's like kind of an initial brief acceleration of their heart rate and an elevation of their blood pressure, but quickly followed by a deceleration of that heart rate and that drop. And so we find sometimes, you've probably heard of people fainting at the sight of blood, or and that's what's happening there. Specific phobias are actually the most prevalent anxiety disorder in the US, and experienced by very many people. And we find that those prevalence rates are similar to European countries as well, but that generally there are lower rates of specific phobias in Asian, African, and Latin American countries. So the US and the European countries are largely the same prevalence, around 7 to 9% at any given moment. But the Asian, African, Latin American countries are closer to like 2 to 4% at any given time. Sometimes we see that these phobias develop after a traumatic event, like if someone is attacked by an animal and then they develop a phobia about that animal, or they get stuck in an elevator and they develop that claustrophobia, right, and fear of being in enclosed places. Sometimes it's through seeing someone else go through a traumatic event, like watching someone drown, or if they have an unexpected panic attack in a situation like on the subway, and they may develop an intense fear of tunnels or being underground, or sometimes even through hearing about things like extensive media coverage of a plane crash. Can sometimes trigger phobias for individuals. Usually though, for most people, they say they've always had this fear. They can't really pinpoint a trigger. It often starts in childhood, and most of the cases of specific phobia, when we look back, developed sometime before the person was 10 years old. Now, it's likely to kind of wax and wane over the course of the lifetime, where it'll be better at sometimes and worse at others. However, what we do know is that if the phobia persists, into adulthood and throughout, that it's unlikely to go away on its own without treatment. Okay. And even though most of these phobias develop in, childhood and adolescence, it is possible for an adult to develop a phobia as well. And often that's the result, like I said, of some kind of event, some kind of traumatic event or something. So like we know that most people who develop a fear of choking in adulthood, it's preceded by a near choking event. Right. So that often is like a very close connection. Again, some kind of culture related issues. We see that Asian Americans and Hispanic Americans often report significantly lower rates of phobias than, say, non-Latino white folks or African Americans or Native Americans. And so, that's something to kind of, take into account and consider, as we're looking at these specific phobias. Some countries outside of the US, like Asian and African countries, will often have different content of phobia too. And so we see, things that the phobic objects are different in different places as well. Right? Which makes sense because there are things that people experience, in different places. Let's take a look. I've got another video clip. Okay, and this one is about specific phobia, and this is a real person who's going to tell us a little bit about her specific fear. Okay.
The first time I really experienced fear was when I first went on an airplane. I was probably 9 years old, and once we took off and I realized how high in the air we were, I had to go to the washroom and I couldn't stand up from my seat because I thought that I would fall through the floor. My name is Ruth Ann, and I have two specific phobias. One is a fear of heights, and the other is a fear of enclosed spaces. I've never had a bad experience in an elevator ever. I just feel very uncomfortable knowing that I can't get out when I want to get out. When I'm faced with the fear of heights or of claustrophobia, I feel paralyzed. I feel like I can't move, I can't do anything to help myself if I fall or if I'm stuck. It's kind of the feeling of helplessness. And that comes with accelerated heart rate. I'll get all clammy, my hands will get sweaty, my feet will get sweaty. I'll get really, really hot. And then once I'm relieved of the stress, I'll get super cold and shaky. So it's all really physical.
People use the term phobia very, very casually, but in reality, a phobia is a problem where you're anxious about a particular situation and it causes so much difficulty in your life that you have a lot of distress or a lot of interference with your functioning. It turns out that phobias and specific phobias cause more interference than expected with people, actually, and they're, again, very common.
When other people would see my physical symptoms or physical reaction to a specific phobia like enclosed spaces or heights, I would be really embarrassed, and people don't often understand. They're like, oh, you can't drive in heavy traffic? Oh, you can't get on an elevator? And it seems so trivial and silly. So then that in itself embarrasses me, and it makes me not want to try those things in front of people because I feel like I'm going to be judged.
All anxiety problems, it turns out that the most powerful aspect of the treatment is what we call facing your fear. So when people face any fear they have repeatedly, even a worry or something that hasn't happened or is unlikely to happen, if they face it repeatedly, we're built actually so that the anxiety goes down.
When I went to Toronto, I wanted to go up the CN Tower. It took me about probably an hour and a half to get on the elevator. And I went up and I made myself look out the window without covering my eyes, and I didn't try and take control of the situation. I just let myself be vulnerable. And once I was up there, I was like, oh, I did it. Okay, cool. And now every time I get in an elevator, it's like, well, if you could go up the CN Tower, you can get in the 6th floor elevator. Getting through a fear is facing it. Once you face it and realize that you can do it, makes you so much less afraid of it.
Part of my job as a psychologist is to help people break these problems down into gradual steps so it's not overwhelming to them to face their fear. You want to make it comfortable for them so that they can see progress and make a commitment to take on the treatment.
I've realized that if you don't go through anxiety, there's no other way around it. I think the best help that I ever got was just talking out loud to someone who understands. You realize that everything is validated and that you're not crazy and that you'll be fine. Just trying means you're going somewhere.
Okay. So again, hearing from, a real person who, has lived with these, difficulties. And, for everybody, for whatever specific thing they're afraid of, there's often two different things that they're afraid of related to it, right? Even being in an elevator, some people may be afraid of getting stuck. Some people may be afraid of having a panic attack. So there could also be different feared consequences, even for one single feared object. Okay, it is time for us to take another 5-minute break. Okay, it's 2:25. Let us come back at 2:30. Again, get yourself something to drink, take a little walk, take care of yourself in some little way, and we will see you at 2:30. Okay, everyone, it is 2:30. So let's all come back and rejoin. Sorry, these videos, I don't know why when I try to go to the next slide, they start themselves over. Sorry about that. Okay, so our next anxiety disorder that we're going to take a look at is social anxiety disorder. So the essential feature here is an intense fear or anxiety of social situations where the person feels like they may be scrutinized or judged by others. When a person with social anxiety disorder is exposed to social situations, they feel like they're going to be negatively evaluated. So there's a concern that they're going to be judged as often it's, as anxious, as weak, crazy, stupid, boring, maybe intimidating, dirty, unlikable. This is where these beliefs often fall for most people. For these folks, they're afraid that, if they act or appear, to be a certain way or show anxiety symptoms like blushing or shaking, sweating, stumbling over words, or even staring, that, people are going to think badly of them. Some people will fear offending other people and being, socially rejected as well. So like, some of those kinds of things too can also be cultural related. That may be, in more collectivistic cultures, sort of a staring or a gaze or showing anxiety symptoms, may be more prominent fear in those types of cultures. We'll see that folks who, like, let's say if they're afraid of their handshaking and that being the tell that they're anxious, they might avoid, drinking or eating or writing or even pointing at things in public, right? For someone who's afraid of sweating, right, that will give away their anxiety. They might avoid shaking hands with people or maybe even like eating spicy foods. Okay? Someone who's afraid that they will blush, which will give away their anxiety, might avoid like public speaking or brightly lit rooms even, or discussing like sensitive topics that might make them blush. Sometimes people will see folks with social anxiety who won't use public restrooms because they are afraid of being judged when someone hears them using the restroom. So these situations, are provoking a lot of fear and anxiety for folks. There's often too anticipatory anxiety that can happen sometimes far in advance of these upcoming situations. So we'll have someone who's worrying, for weeks before a social event comes up, or who's repeatedly practicing a speech for hours and hours, days in advance of the speech happening that they have to give like at school or something. So individuals with social anxiety will often avoid these feared social situations, or they will use those kinds of, safety behaviors. So, they just might not go to parties, or they might not go to school. Or maybe, like I said, they're over preparing for, a presentation that they have to give at school, or they are, diverting attention to other people, or not making a lot of eye contact when they're in social situations. We can also kind of see that individuals who are suffering with social anxiety may be sort of unassertive, right? They may come across as kind of submissive. Or on the other hand, we could see that they, in order to try to make up for their perceived deficits, They may be highly controlling of the conversation. So, it's this sense of, I know that I'm good with talking about, this particular topic. And so they're always trying to turn the topic of conversation towards something they know about so that they don't appear stupid or dumb. Sometimes we'll see, sort of physically, they may be rigid, right? You may be able to, see just kind of how stiff they are. Or again, we may see that they're not making a whole lot of eye contact, right? Often they are prone to not disclosing a whole lot in conversation, again, for fear of scrutiny. Often with individuals with social anxiety, if they're not going to school and not working, which is often the case, then, they don't like to disclose that information because they feel like people are going to judge them for it. And so, again, they're stuck in this cycle. We find that people with social anxiety disorder tend to live at home longer. They tend to try to self-medicate. If they do have to go somewhere, they might drink alcohol, or I've even heard of people using like NyQuil or something to, help them to calm their nerves before going to a social event. For most people, social anxiety disorder actually develops in the early teen years. And we know that for about 75% of people, they've had the diagnosis since before the age of 15. Right? So those early teen years is often where this emerges. Again, these kids are often described as, excessively shy, even in, early childhood. Sometimes social anxiety will develop, following a stressful or kind of humiliating experience. If someone is being bullied at school, or if they are, giving a presentation at school and they vomit, something that they feel like is embarrassing. It may not have a specific trigger. Now, it's relatively rare for social anxiety to develop in adulthood, but it is more likely to happen if there is a stressful or kind of humiliating event that occurs for someone, or sometimes after changes in life that require new social roles. Like, getting a promotion at work, or, marrying someone from a different culture, let's say. And sometimes the person starts to become more introspective about what others may think of them given these new roles. And we'll see sometimes in those cases that, the anxiety may diminish over time, as the person is, getting used to that role. But when there's that avoidance present, we often see that, the anxiety will tend to persist. There's about 30% of people with social anxiety who will experience remission without treatment, in any given year. And about 50% of people will experience remission within a few years. But for the majority of people, they can experience this intense social anxiety for several years unless they get treatment. Sometimes, again, we can look at some culture-related issues, like there are specific, kinds of cultural syndromes, like in Japan and Korea, that are characterized by these kinds of evaluative social concerns. So there's like an idea of something about themselves that would make other people uncomfortable. For example, like, my gaze upsets people, so that they look away and avoid me, right? So that's something that we hear sometimes in, some Asian cultures of these kinds of concerns about making other people uncomfortable. Now, functionally, social anxiety disorder can be, pretty devastating. We see that often individuals with social anxiety are, dropping out of school or, not continuing with school as they would like. They have, lower quality of life, less employment. If they are working, they're usually less productive, and end up, sort of just really having a lot of these kinds of issues. That they're less likely to be married, right? More likely to, if they've married, to have divorced, more likely to not have children. So we can see that this anxiety can really take a toll on their life, like in addition to, kind of the fun stuff that they might want to do, like hanging out with friends and doing that. It actually will, it's interfering with the rest of their lives too. Okay. Let's take a look at, again, another short video clip looking at social anxiety. Let's hear from someone who's living with this.
I used to joke, and I guess I still can joke, that I was born with high anxiety. I always walked with that feeling that there's just something wrong. Why do I feel so uncomfortable? Like, what are they thinking? That feeling of not measuring up as a person.
Social anxiety, in a nutshell, is basically an extreme fear of negative evaluation from other people. Now, most of us will have some of that, and that's very normal. But any kind of anxiety disorder really comes from an excessive amount of anxiety when we find that it starts to interfere with our everyday life or the things that we want to do.
My name is Les. If I would be in a group of people at work, I would try and fit in, but some comments I would make would either be so off the mark of what they were talking about, or I would just blurt something out without thinking about it, and then everybody would stop and just, they'd look at me. So I would feel like I wasn't a part of the group, even though I was there physically. I was so detached from so many situations, it caused me to come to believe that I was going crazy.
There's actually several different symptoms you can have. There are what we call cognitive symptoms, and they're usually thoughts related to a particular concern, like a worry. Thoughts about what other people are thinking about you, usually derogatory comments about yourself. I'll never get through this. People are judging me. People are watching me. So that's one aspect of the symptom. And the physical symptoms often would be shortness of breath, rapid heart rate, dizziness, nausea, but also things like stammering, blushing, turning red, shaking. So those are a lot of the physical symptoms that you have.
I had a lot of trouble relating to people, and I think as a result, I was really cautious when getting to know someone. I didn't really want to let a lot out of the bag, or I just didn't want to let people in. There's moments when you're asked to go out to a party or to a club to watch a band or something. I felt so self-conscious that even finding clothing to wear would be such a challenge that I would end up canceling and calling them and saying, oh, I'm not feeling well, or I'm too busy working. There would all be an excuse to avoid going out in public. Therefore, I had a lot of difficulty with relationships socially, romantically, and in the workplace. And I just felt, people either couldn't understand, won't understand, won't like it if I showed my true self, whatever that was, because I was still trying to figure that out.
And when we become anxious as people, or socially anxious, our thoughts aren't always accurate. They're negative, but they're not accurate. They're unrealistic, or they're not solution focused. Because when we're anxious, we get stuck in a pattern of automatic negative thoughts.
When I'm in the throes of anxiety, I'm out there. I can't focus. Coming into recovery was such a wonderful experience, because for the first time, I had the feeling that I wasn't alone, and that there were other people out there that were feeling a great deal of the pain that I was feeling. They were also feeling a great deal of the loneliness that I had come to feel. So to be in this group of people was really exciting because they could relate and I can relate. And then when I heard their stories, I felt like, all right, it's okay. I wasn't the only one walking that journey.
Many people will vary in terms of how much help they need. Sometimes we can make use of peer support, and that can be a really good way, and many people find that very helpful.
My life is unfolding, I think, the way it was meant to be. I can feel positive about the things that are happening in my life and the direction that I'm headed in. I keep finding out more about myself, and I'm just putting one foot in front of the other, and it feels good. Today I can, be in a room and not feel terribly uncomfortable. I might get a tingle of nervousness, but I understand that everybody is feeling that. So I'm no different than anyone, and that's another revelation because I always thought I was unique, but I'm unique as me. But you know what? I'm just like everyone else, and that is a wonderful feeling.
So that is something that we actually see often as well is, there's this such an internal focus on, how I am portraying myself to the world and thinking that everyone is judging you, when really, so many people feel a little bit anxious in social situations, and most people aren't paying attention to, the little bits of information that individuals with social anxiety are so trying to be so protective of, so that they don't, give away their anxiety. So I think that's a good representation of, kind of what social anxiety can feel like. Okay, so our next anxiety disorder is panic disorder. So panic disorder refers to really recurrent, unexpected panic attacks. Now, a panic attack is an abrupt surge of intense fear or intense discomfort that kind of reaches a peak within a few minutes. And during that time, at least 4 of the 13, kind of physical and cognitive symptoms that are listed will occur. Now, we are looking at, both expected and unexpected panic attacks. So unexpected means that there's no obvious cue or trigger when it happens. Kind of comes out of the blue, right? We will often hear individuals with panic disorder talk about when they're waking up. So nothing happened. They weren't dreaming of anything. They just wake up and all of a sudden have a panic attack. That would be an unexpected, no obvious cue or trigger. In contrast, an expected panic attack is one where there is an obvious cue, a situation where, maybe panic attacks typically occur for the person. Now, the frequency, the severity of panic attacks can vary widely, right? Some people may have, moderately frequent attacks, like once a week for months at a time, or short bursts of more frequent panic attacks where, maybe they're happening daily or several times a day, separated then by weeks or months without any attacks, or, less frequent attacks, like one a month. Okay. And that kind of cycle can happen over many years. In terms of severity, we can see folks with panic disorder who have both full symptoms, so 4 or more of these symptoms, or limited symptom, which is less than 4 symptoms. So they can have, either one of those types. And that we can see that can differ from one panic attack to the next as well. What is also important with panic disorder is that the person worries about having another panic attack or about the consequences of having another panic attack. Usually this is related to physical concerns like worrying that the panic attack means there's some sort of life-threatening physical thing going on, like they're going to have a heart attack or they're going to have a seizure. But people will also worry about social concerns like embarrassing themselves or, being afraid that people will, think that there's something wrong with them if they behave like this in public or have a panic attack in public. Or people who are afraid of kind of long-term psychological injury, like, they're going to go crazy or they're going to lose control forever. Those are some of the things that people are often worrying about when they're worrying about having a panic attack. In addition to the symptoms themselves being, quite uncomfortable. Right? That it's not comfortable to, have your heart racing and sort of have chills and feel like you can't breathe, etc. Okay. What happens with panic disorder is that when these kinds of symptoms begin, often individuals are doing whatever they can to minimize or avoid a full-fledged panic attack or the consequences of it. So sometimes we'll find that not only in the moment, if they start to have those symptoms, but even beforehand. So people might start avoiding physical activity because that may trigger a panic attack. Or they might reorganize their life to ensure that, help is always available in case they have a panic attack. They might start restricting things like they don't drink coffee or caffeine anymore because that might trigger a panic attack. And often panic, and we'll talk about agoraphobia next, often panic and agoraphobia go hand in hand because with agoraphobia, the person is afraid of, leaving a safe place. And that's often what's happening in panic disorder as well, is that these individuals are afraid to, leave home or, go on public transportation or be in a place where escape might be difficult or getting help might be difficult. Again, some, thinking about some of the, associated features of panic disorder. I mentioned this idea of like this waking panic attack where someone wakes up in a state of panic. This is often very confusing for people who experience it because they don't know why they would have something like this happen to them. And again, they will often do things to try to mitigate that. So, they will have snacks in their, bedside drawer because that seems to help the panic attack go away, or, something that like a bottle of water always near them when they're sleeping, so that if they wake up with this panic attack, that they can try and do something about it. In addition to kind of the worry about panic attacks and their consequences, many people with panic disorder often report sort of, constant or intermittent sort of feelings of anxiety that are more kind of broadly and generally related to like health and mental health concerns. So that this is a big focus for them is, on their physical and mental health in general. Right, which may explain too why these panic attacks then become so overwhelming. There might also be kind of concern about a person's ability to, complete daily tasks or withstand daily stressors. In general, individuals with panic disorder may start to feel like they're more fragile. They can't handle, life as well. Sometimes we'll see people turning to, drugs or alcohol to try to control panic attacks, or, sort of, as I mentioned, using or overusing prescribed medication, even to try to control these. Panic disorder often develops in the early 20s, so in early adulthood. Now, we do see some kids and adolescents develop panic, and we do see some older adults develop panic disorder, but usually the median age is somewhere between 20 and 24. The course, as we mentioned, is chronic, right, where it will last, but at times there may be no panic attacks for several weeks or months at a time, and at times there may be daily, very frequent panic attacks. Most people will retain the panic attacks without treatment in some form. Again, even though it may kind of wax and wane, they will not kind of experience full remission unless they get some sort of treatment for it after a while. Although we do, only rarely see panic attacks in younger kids, when we look back kind of retrospectively with our adult clients, we'll often hear, things that sound like panic attacks that may have occurred when they were younger. And so it's not something that comes to clinical attention often when they're children, but they can often kind of point back to, times when they had these sort of anxiety spells when they were younger. Culturally, we see that, kind of the rate of fears about, mental and somatic kinds of symptoms of anxiety vary across cultures. And so that might influence the rate of panic disorder and panic attacks that we see in various cultures. There also may be some, sort of cultural expectations that could influence how panic attacks are classified as either like expected or unexpected. So again, in certain cultures, there are, cultural ideas about, sort of being, walking into a windy environment, let's say, and that may cause a panic attack. And so while this is actually in Vietnamese culture, that would be an expected panic attack because it's something that culturally has been linked together. For other cultures, the idea of, walking into a windy environment does not equal panic attack for us. And so that would seem unexpected for someone who's not in Vietnamese culture. Also, the kind of specific worries are likely to vary between cultures. So that, whether we're worried about the physical consequences, like having a heart attack versus the social embarrassment, et cetera, is going to vary. Functionally, we see that panic disorder is really highly associated with, social, occupational, physical problems, right? A lot of costs. Again, people with panic disorder may often feel like they have difficulty with, performing the everyday tasks of life. And so, may be less employed or employed less often. And may also, they have a higher incidence of developing agoraphobia, like I said, which we'll talk about next, which then, makes it less likely that they're able to work outside the home. Okay. People with panic disorder may often miss work or school because of their symptoms, often will visit doctors and emergency rooms, particularly when they're having these symptoms, again, because they're afraid that something physical is happening. And so that can also impact, their ability to stay in school or to keep a job. Let's take a look at another example of someone talking about their experience with panic disorder.
My name is Jamie Dixon, and I had panic attacks for a number of years. The first thing I feel when I start to have a panic attack, I feel it in my stomach. and then my heart and my breathing come directly after. So I can kind of, at first when I didn't really know what panic was, I didn't know what that feeling was, and so I didn't really know how to identify it, and it would get into my heart and my breathing very quickly, and I'd start hyperventilating, and kind of my whole body would just turn into a shaking mess.
Panic attacks are really common. Everyone I know has had a panic attack at some point in time. A panic attack is your body's natural response to feeling threatened. Sometimes it's referred to as the fight or flight response. So your heart rate increases dramatically. You get short of breath and lightheaded. You may feel numbness or tingling in your limbs. You might get a little nauseous, and you get this bolt of adrenaline, almost like a tingling that goes through your whole body. And that experience tends to peak within 10 minutes, but often 10 seconds, and will go forward from there and taper off over the next 30 to 45 minutes.
It's really hard to describe the feeling of being separated from reality, because it's unreal. You kind of feel like your body's a bit of almost like rubber. You can't quite, like, sitting isn't comfortable, standing isn't comfortable, moving around. You kind of like, there's nothing that you can feel solid in.
People think they're having a heart attack, people think they're dying, people think they're going crazy. It's really common for people after their first panic attack to end up going to the emergency room and saying, check me out because something's killing me right now.
I wasn't talking to anyone about it. Again, I had no words to describe. I had no idea, like the words like panic and anxiety just didn't even really enter my mind. I just knew that I'd start hyperventilating, have this crazy attack. It would somehow start to fade and I'd continue on.
That's part of what makes it so scary, is when it's unpredictable and we're desperately looking for answers. So they had a panic attack at the grocery store. And they go, well, it must have been something, so it was the grocery store. And so now they don't go to the grocery store because that grocery store causes panic. And then it wasn't really the grocery store that caused the panic, so then they had a panic attack driving, and now they can't drive anymore. And their world shrinks and it shrinks and it shrinks until they're what we call agoraphobic, where they're just avoiding all public places because they're worried about having a panic attack in those situations. And they become kind of trapped in their own tiny, tiny world, but still as anxious as ever.
It wasn't any one situation, any one thing, because sometimes I would have one in a certain situation and sometimes I wouldn't. So I was never sure when it was going to come up. It wasn't even a thing where I could say, I always have panic attacks on the bus, or I always have panic attacks when I get groceries, because that wasn't the case. And so knew that I needed someone to kind of help me see what it was that was causing them, because I wasn't able to put my finger on what was causing my panic attacks.
So there are two common effective treatments for panic disorder. The first one, and the one that people get most often right off the hop because they can get it from their family doctor, is antidepressants. The other treatment that's usually provided is therapy. Specifically, cognitive behavior therapy is probably the most supported scientifically. And that treatment involves seeing someone who specializes in helping people essentially get better at getting anxious. One of the things I tell my patients all the time when they start is my goal is not to keep them from getting anxious. We need to be able to get anxious in order to live life. So we're not trying to come up with ways not to feel anxious. We're trying to come up with ways to get through it and be stronger on the other side of it.
It's daunting but freeing to realize that I had these huge walls up around me, but that I actually had all the power to break them down. And so slowly I am. And the thing I love the most that I learned was that, I challenge my panic attacks now. So as soon as I get that feeling, I say, like, bring it on, panic, let's see. And it always dissipates. There's like never a panic attack when I just think like face to face, let's go, have a panic attack right now. And I don't. Because that's all it is the fear of having that panic that creates that panic. So when I call it on, it backs down, and it's a really cool feeling.
So, you can hear again this like personal sort of story of what it's like to have a panic attack. And, I think it's interesting that the therapist there is talking about how, while many people are coming to us saying, I want to feel less anxious and I want this to go away, what we know about treating anxiety is that the only way to get past it is to go through it. We can't go around it. We can't make it, so we have to actually bring on anxiety before we can reduce the anxiety. So that's often a little bit of a learning curve for people as they're looking for help with anxiety. Okay, our next anxiety disorder is agoraphobia, which it's very, very linked with panic. And so we've been talking about it a little bit. The popular idea of agoraphobia is a person who will not leave their house, but that's not always the case. There are less severe cases of agoraphobia. And really, agoraphobia is any kind of like intense fear or anxiety about, kind of a wide range of situations. So it could be using public transportation, right? Like cars, buses, subways, right? Planes. It could be about being in open spaces, like in open parking lots or marketplaces or on bridges. It could be about being in enclosed spaces, right? In, small shops or in theaters or something like that. Could be about standing in line or being in a crowd. Or again, as the most popular kind of representations of it, of being outside of the house at all alone. When the fear and anxiety are cued by this situation, whatever one of these it is, the person will typically, kind of fear that something terrible is going to happen. Often it's about, the fear is about not being able to escape from the situation. They won't be able to get out of there, or again, that they won't be able to get help, right? Because, or, in case they have these like panic symptoms or panic-like symptoms, or even if other kinds of incapacitating or maybe embarrassing symptoms might occur. Okay. So that might be something like, vomiting or, having diarrhea, that, some people will say that that's why I don't like to go out, or I don't like to be in these situations where I can't get out of them, because what if I have, one of these attacks, right? In older adults, we'll sometimes see that agoraphobia develops as a result of being afraid of like falling, or in younger kids, sometimes of like they'll be afraid of getting lost, right? So there can be different fears even across the developmental lifespan. We'll see that people are actively avoiding these situations, or if they can't, that they're, again, maybe they need to have someone with them if they, go on the subway, or if they go on a plane, or they do something to, something else to try to make it feel safer. Okay. We'll see people, again, avoiding lots of different things, even changing their life, changing their daily routines, which job they choose to take, having food delivered and groceries delivered all the time, in order to avoid having to go out. But we can also see that people will use kind of cognitive avoidance too, try to like distract themselves to get through a situation that's scary for them. As I mentioned, it can become so severe that the person can be completely homebound. And often what we'll see is that they will say they, kind of need someone to go with them in order to have that safety net if they are going out or doing something. When people are completely homebound and, unable to, leave the house on their own, it means that they require a lot of special services and a lot of assistance to kind of provide even for, basic human needs. Also, we see a high incidence of depressive symptoms, and, use of alcohol or, kind of sedative medications that are used to kind of self-medicate for the person. In terms of prevalence, we see that the prevalence is pretty low in younger kids, but in adolescents and adults, we see about 2% of people will have agoraphobia. Women are more likely to experience it than men. And as I said, although it might, occur in childhood, it's usually pretty rare. Usually with folks who have agoraphobia, if they do have panic attacks and that fear of panic attacks, that often precedes the agoraphobia. So the agoraphobia develops later. And that's typically how, the agoraphobia will develop for that. For most people, the onset of agoraphobia is before the age of 35. So sometime in, again, sort of early adulthood, where this will occur, or, onset will begin. The course is usually pretty persistent and chronic. Remission is rare unless the agoraphobia is treated. Functionally, you can, probably imagine how impairing this could be, resulting in people really pretty much being almost, disabled in terms of role functioning and, work productivity and that sort of thing. And the estimates are actually that, about a third of people who have agoraphobia are completely homebound. And so it's a good portion of people where, they aren't able to leave the house at all. Let's take, I have another video. Before we watch, let's take another 5-minute break, okay? I went a minute over my planned time. So let's come back at 3:17 now. So we'll take 5 minutes, come back at 3:17, and we will watch a little short clip on agoraphobia. Okay, everyone, it is time to come back from break. Thank you very much. So we're going to move right into looking again at a short 5-minute video clip of a person who talks about her struggles with agoraphobia.
I suffer from panic disorder with agoraphobia. This all started after an absolutely horrific accident. We had a family gathering. Everybody was having a good time. Out of nowhere, my cousin got up and slapped me. I don't know where it came from. After the incident, we get maybe a block or two away. All of a sudden, this truck rammed into my car. It was my cousin, the one that slapped me. My first thought was to get away, and I just took off. He chased me. I felt that this person was coming to kill me, and I didn't know why. He only stopped because he had a flat tire. It took almost a year before I started feeling any symptoms of panic, and it started in a car. All of a sudden, my heart is beating out of my chest. It got very bad to where I couldn't go to work anymore. I don't leave here. I don't go to stores. The furthest that I've gone is up and down my block. I've lost out on family gatherings and trips. I have not been able to do everything that I want to do with my son. I want to take cupcakes to his school for his birthday and watch him go get an award. But when I think about leaving here, the panic takes over.
Hi, Teresa.
Hello, Dr. Rachel.
Hi. Oh my God. So, Teresa, how long have you been dealing with your agoraphobia or your fear of leaving the house?
It has been 10, 11 years.
Well, you know, I came all the way from Chicago. How about we go and see if we can go for a little walk?
That's the least I can do for you.
Okay. So what do you think you're afraid of? If you go past that point, what's about to happen?
I feel maybe that it'll take too long for me to get help if I need it. I'm too far away from home.
That you may need help and there won't be anybody there to help you.
Mm-hmm.
How are we feeling?
A little anxious.
A little anxious?
Yeah. You want me to go further?
Yeah, let's see if we can go to this tree right here.
Okay, turn around.
Experience it. You know? Deep breath. How you feeling?
I'm just starting to tear up, like the panic is coming in and my heart is beating really fast.
Knowing that Teresa wanted to take the steps needed to finally free herself of her agoraphobia.
I'm going to pause us there. So you can see, you know, what this is, how debilitating this can be, right? That, you know, I mean, this woman is talking about she can't even bring cupcakes into her son's school, right, for his birthday. That even that, right, something she starts to tear up about isn't enough of a motivator to get her out because of this fear, okay? So these symptoms, these things can be, you know, quite debilitating and, you know, ruin a person's life for sure. Okay,
we set her up.
Let's move on to talk a little bit about generalized anxiety disorder. Okay. Generalized anxiety disorder is the last of the official anxiety disorders. Again, that official list that we're going to talk about. And this one, you know, I should mention that it, I think, sometimes gets confused with the idea of someone just being anxious in general, which is not quite what we're talking about here. Generalized anxiety is, you know, excessive anxiety and worry or about a number of different kinds of things, right? Usually that intensity, that duration, that frequency of the anxiety and worry is out of proportion to the actual likelihood or impact of the anticipated event. People with GAD will find it difficult to control the worry or to keep those kinds of worried thoughts at bay or from interfering with their ability to, you know, pay attention to the stuff they, you know, need to pay attention to in the moment. This is where people are often, worrying about everyday routine stuff like, their job responsibilities, health, finances, the health of their family members, bad things that might happen to their kids, minor things like being late for appointments or, being able to get household like chores done or something. In kids, we often see that their worries tend to be, a little bit more about their own competence or the quality of their like performance in school, that sort of thing. And, the worries can shift. It's not like, someone will have one thing that they specifically worry about, but it can change from time to time, from, week to week or year to year. And people may worry about several different things at once. Okay? Now, what distinguishes this from, again, kind of just a general anxiety and not generalized anxiety disorder is that, remember, the worries here are excessive and they're interfering with functioning. Whereas worries in everyday life, aren't excessive. They aren't perceived as unmanageable. It's, we might be worried about something, but we can say, okay, I'm done worrying about this now, or I'm going to put it to the side and think about something else. And that feels like an impossible task to someone with GAD. Second, the worries tend to be more pervasive, more pronounced, more distressing. Right? The person will find themselves worrying for long periods of time and frequently worrying without any trigger. It just comes to mind. Also, the, kind of everyday worries that many people will have aren't very likely to be accompanied by physical symptoms like restlessness or, feeling keyed up or on edge. Whereas GAD often has these associated kinds of physical symptoms, okay? The restlessness, the feeling on edge, being easily tired out, having trouble concentrating, right? Being irritable, muscle tension, trouble sleeping. Okay. All of these things are accompanying these worries and this anxiety when we have GAD. In addition to muscle tension, we may see trembling or twitching, feeling shaky, muscle aches or soreness. There may be other kinds of somatic sorts of symptoms like nausea or diarrhea, right? We don't see as much of the rapid heart rate or shortness of breath or dizziness with GAD, although it might occur, but we're more likely to see that in a panic disorder rather than generalized anxiety. For people with GAD, they will often report that they've been worriers all of their lives. That's like the mantra that, I hear from every person with GAD. I've been a worrier all my life. Usually the diagnosis is happening before the age of 30, although, it can kind of occur at any point really during the lifespan, even with younger kids. Although it's rarer to see a kid younger than a teenager be diagnosed with generalized anxiety disorder. Again, the symptoms are often chronic, wax and wane, across the lifespan. And, at sometimes be, very problematic and sometimes be, almost hardly noticeable. I think I'm actually going to skip the video in the interest of time. I'm going to skip the video for generalized anxiety disorder in favor of being sure that we have time to talk about some of the other disorders and another video or two that I have planned. So let's move on to talk about OCD or obsessive compulsive disorder. So in OCD, we have this idea of, recurrent, persistent, intrusive thoughts, images, or impulses that cause severe anxiety or distress, right? So these are the obsessions, the first part of the obsessive compulsive disorder. It's good to remember that obsessions are, experienced as involuntary. It's not something that the person is trying to think about. They're intrusive, they're unwanted. They cause this anxiety, so they're not, bringing up these thoughts on purpose. What often happens is that the person tries to ignore or sort of suppress these thoughts, or avoid triggers that, will bring up the thoughts, or they try to neutralize them with some other kind of thought or action, which is, performing a compulsion. So a compulsion or a ritual, those terms are used interchangeably, are repeated behaviors. They could be something like washing or checking, or mental acts, counting things or repeating words silently that the person feels driven to do in response to the obsession, or according to certain rules that have to be kind of rigidly applied. So most people with OCD are going to have both obsessions and compulsions, and they go in hand with each other. And the compulsions are usually performed in response to this. So, the obsession of being contaminated, thinking that you're contaminated, will lead to, washing rituals, let's say. Or the obsession that something is incorrect may lead to repeating rituals until something feels just right. So the goal with a compulsion is to reduce the distress that's triggered by the obsession, or to prevent some feared outcome from happening, like becoming sick, right? The problem is that these compulsions are either not connected in like a realistic way to the feared event. So, if someone is arranging items on their desk symmetrically to prevent harm from coming to someone that they care about, that doesn't, they're not connected in a realistic way. Or that these measures are like clearly excessive. So, being in the shower for several hours each day is clearly excessive. Okay? Again, the important piece of the compulsion is that its function is to, reduce or neutralize those obsessive thoughts. Okay? There are lots of different content of obsessions and compulsions, or themes. Cleaning is a big one, or contamination obsessions and cleaning compulsions. Symmetry and exactness is another one, wanting things to be ordered and, or set up in a certain way. Repeating things or counting things. Having kind of forbidden or taboo thoughts, like aggressive sexual thoughts, or religious kinds of obsessions and related compulsions. And another big area is harm obsessions and compulsions, fear of harming oneself or others. And again, and this isn't like a suicidal or homicidal thought. This is a fear of it. It's, what if I lost control and, killed my family? Not, I would like to do that, right? So there's that difference there. We know that this is something that is often occurring, again, early adulthood. So by the age of 20, usually most people who have OCD have experienced those symptoms by that time, and can even occur in younger kids as well. We definitely see a good amount of children who are experiencing OCD symptoms. We know that OCD occurs around the world. There's a lot of similarity in, sort of the gender distribution of OCD, the age of onset, all of that in lots of different cultures around the world. And, often to see that there's, similar kind of symptom structures around cleaning, symmetry, taboo thoughts, all of those things that we were talking about. Again, OCD can also be very debilitating. There are some people who really are just, unable to do anything in life as a result of having to spend the time with the OCD symptoms, doing compulsions, or being kind of frozen by the obsessions. So let's take a quick look at a video. I decided to show just a little video of a kind of a young adult child who is experiencing OCD symptoms, just to kind of mix it up a little bit. And like I said, to show that these will, happen in kids as well.
In many ways, Matthew is a typical 12-year-old. He loves video games, basketball, and his dog Maddie. But there is something different about Matthew. He describes it as an internal voice focused on his fears.
What's the name you gave it?
Mental convincer.
The mental convincer?
Yeah.
What was the voice saying?
What if I wanted to hurt myself or something like that, and then I started getting really nervous and I didn't know what to do, and then the thought just kept on rolling and rolling in my head.
Matthew has obsessive compulsive disorder, or pediatric OCD, a brain disorder in which obsessive thoughts lead to extreme anxiety and compulsive behavior trying to reduce that anxiety.
I used to have to keep my chair in and facing myself, or else I couldn't sleep. So when I'm going to sleep, it had to be like this, always. And with the door, I used to have it all the way open. I did it because I felt like it just had to be that way, or else I just couldn't function in the day or go to bed.
He had trouble separating fantasy and reality, and that scares him, and rightly so, because you feel like you don't have control of your mind.
There are an estimated 500,000 children and teenagers who have OCD. That's about 1 in every 200. The same number of children who have diabetes. And oftentimes it's genetic, particularly when it starts in childhood.
I had OCD as a child, and I still have tendencies toward it as an adult.
OCD affects not just Matthew, but the whole family.
It was hard on the household because anywhere someone was watching TV, if he saw something that scared him, he would pick up on it, and then it would affect him for the rest of the evening.
Do you think you could have handled this without therapy, without outside help?
No, absolutely not.
I think about it a lot like a medical disorder like asthma or like high blood pressure that can effectively be managed and can effectively be treated even if it's not fully cured.
Dr. Anthony Pugliafico is a psychologist who specializes in treating pediatric OCD like Matthew's with an intense behavior modification therapy called cognitive behavioral therapy, or CBT.
It really involves gradually guiding the individual to face the types of situations that bring up obsessions and are, in turn, anxiety-provoking, and helping that individual, helping the child to resist compulsions in those situations.
Matthew's therapy includes daily charts that limit and even eliminate his compulsions.
I have one for washing my hands at the time that I'm supposed to, which is before I eat.
According to the International OCD Foundation, cognitive behavior therapy is extremely effective, resulting in as much as an 80% decrease in OCD symptoms. But because it is so demanding, about 1 in 4 OCD patients refuse to do it.
As much as their OCD might be impairing their lives, the idea of changing, the idea of facing these fears is terrifying.
Dr. Pugliafico and a research team at Columbia University are studying the brain to better understand causes of OCD and how various drug and behavior therapy combinations can improve treatment.
Do you see a different child now?
Yeah, definitely. It's freed him from some of these things that he couldn't do to doing so many things that he loves to do.
I feel a lot happier, and I feel a lot greater that I don't have to just deal with all these thoughts every day. And even that I feel a lot better, they're still gonna come up, and I'm gonna know how to handle them.
And you can just be a kid, right?
Yeah.
And that's important.
I love you.
Day by day, Matthew is learning to silence the voice in his head and his fears. Lisa Rudolph reporting. In many
So one thing that is that we know about OCD with kids too is that because kids haven't had as much time to get settled into those compulsive routines and are often just more flexible in their thinking than some adults can be, is that they are really usually quick to see those changes when they do participate in treatment. So that's always a nice thing. Okay. I'm not going to talk too much about hoarding disorder. Again, it is one of those disorders that's included in obsessive, compulsive, and related disorders. Has also been given a lot of attention lately in the popular media, for those of you who've seen Hoarders on TV, right? You're probably familiar with it. Basically, it's, difficulty with discarding things or parting with possessions and the associated accumulation of items. To the point where it actually interferes with the person's ability to function in their spaces. So, the kitchen will get filled up so that they can't cook in there. Their bedroom will get filled up so that there's no place to sleep. And so, again, if you've seen the TV show Hoarders, you've seen how debilitating this can be. But in the interest of time, I'm going to move forward to talk a little bit about PTSD. So PTSD, post-traumatic stress disorder, is something that, I didn't mean for these to all be individually clicked, is a reaction to a traumatic event. So many people experience traumatic events in their lives, and for some people, they will experience PTSD symptoms for weeks and sometimes months after that experience. So the exposure to a traumatic event like combat, like sexual assault, like a physical assault, like child sexual abuse, right? All of the different kinds of traumatic experiences that you can think of may result in post-traumatic stress disorder. Now, there are a couple of categories of symptoms that people will experience with PTSD. Intrusion symptoms, where the memory or the thoughts of the trauma are kind of being brought up through, thinking about it, having bad dreams about it, someone having flashbacks, right? And really experiencing extreme emotional distress when they're reminded of what happened, or having really severe physical reactions to being reminded. There's also avoidance symptoms, where individuals are avoiding things that make them think about it. So avoiding internal kinds of reminders and external reminders, people, places, situations that, again, make them remember or that generally now feel unsafe. There's cognition and mood symptoms, where we see people change. There's changes in the way that they think about themselves and the world and other people, or changes in the way they feel about things, right? Feeling guilty for what happened or blaming themselves, those kinds of symptoms. And then finally, there's kind of the arousal or hyperarousal symptoms, where, again, we're talking about that physiological arousal, and we see people being, more aggressive, sometimes more hypervigilant, always on the lookout, always, trying to be more aware of things, having trouble sleeping. Okay. So all of these kinds of reactions are, housed under the umbrella of PTSD symptoms. Again, I have a video I'd like to show to get a firsthand look at what PTSD can look like in real life.
I just shut down. I don't want to be around people. And even to a point when I always have to make sure that no one is behind me, that my back was to a wall, that I always have an avenue of escape. I was just hurting. I would take my daughter and we would just get in the car and ride on the base, because I was comfortable around soldiers. I could relax, bring me down to a level where I was at ease. My daughter It was like she knew that something was wrong with Daddy. Daddy, are you okay? I didn't want to tell her that I've been having these dreams of a trauma that I witnessed when my mentor got killed in the barracks, shooting. I didn't want to put that on her. Because, after she lost her mother, we would always talk, and she would always say things that, I miss Mommy, and I was like, yeah, I miss her too, And so I tried to block her from a lot of things. I was trying to protect her. A lot of times I would have to grab my Bible and just read from the book of Job. That's one of my favorite, because Job lost everything. He lost his wife, he lost his kids, his cattle, he lost everything. And it's hard. I'm not going to sit here and tell you, oh, it was a piece of cake even reading the Bible and praying, and it's still hard. And I was mad at the military because as much as I love the military, it seems like the only solution that they had was, oh, we're there for you, if you ever want to talk about it. But I needed more than talk. I needed more than talk, because this was just looking at him, looking at me with his eye, because when he got shot, when he died, his eyes was wide open. So he was looking at me, so that really, really tore me up. I thought I was protecting her, but actually I was exposing her to something that she didn't even have a clue. I would snap at her in a rage. Got to the point when she would say to me, this is in her teenage, she said, Daddy, she said, instead of talking at me, she said, talk to me. I'm your child, I love you. And I knew it was from the PTSD and the anger, and I knew that I needed some help. And it took about the first 3 months for me to get to a level where I was able to talk about the trauma that I experienced.
So I'm going to pause us there, stop us there. You can see how, again, this is something that happened so long ago for this guy, and yet, in the everyday is still affecting him, is still haunting him, right? And that's kind of the essential feature of PTSD. Now, acute stress disorder is very similar to PTSD, but is only diagnosed in the first kind of month following exposure to a trauma. The idea is that, people are going to experience symptoms related to having experienced a trauma. And so, this is sort of a temporary diagnosis. And if those symptoms persist, then we're looking at a PTSD. Okay? Adjustment disorder is also similar in that it is a reaction to a stressful event. The difference with adjustment disorder is that the stressor doesn't have to be a trauma. It could be a more everyday life example, a divorce, sometimes even, a death in the family, something like that. Okay. And then, I said that I was only going to include some of these at the end, if we had time, and we're running out of it. So I'm just going to briefly mention that somatic symptom disorder is when a person has, multiple kinds of physical symptoms that are distressing them, and that they end up seeking, medical help for, but there is no medical explanation for it. And so, sometimes it's, pain or fatigue or, so it can be specific or non-specific, but is, sort of the answer to the question is not that there is something medically going wrong, but that they are, experiencing these kinds of excessive worry about these symptoms that is medically unexplained. And then illness anxiety disorder is a little bit different. This is what most of us think of as like hypochondria, where a person is concerned about either having or acquiring an illness. And so, again, these individuals are often treatment seeking in the medical side of things. And are finding that, again, they don't have anything, there's nothing wrong, but they continue to have this high level of anxiety about potentially having something wrong, and that the doctors just haven't found it yet. And so they're often pretty dissatisfied with the answers that they get from the docs. Okay, so I want to have time to at least go through one or two of these case examples to kind of just check and see, what people think about some of these, and see if we're on the same track. So what we're going to do is, Emily, if you can, will launching the poll override the PowerPoint? I don't think so. If you want to go ahead and launch the poll, I will talk about this case a little bit. So this case, let's say we have this woman, Mrs. E, who's 91 years old. She lives with her husband of 60 years, and she has an intense fear of falling and dying. She also fears losing consciousness. She's afraid of not being found in time. She's afraid of being buried alive. She stays mostly in her bed, and she doesn't even allow her husband to leave the apartment. So she's really very afraid of dying. She thinks that she may go to hell, which is why she's so afraid of dying, but she can't describe anything that would really, make her deserve that fate. Her niece reports that way back in the day, in the 1950s, when Mrs. E's husband was working, that Mrs. E couldn't tolerate being home alone, and she would call her brother to come pick her up, and she would stay all day over at the brother's house until her husband would be done with work and would come pick her up at the same time every day. Over the years, things have worsened to where she refused to even step out of the apartment. And as time progressed, she eventually even refused to leave her bed and had to be provided with like a bedpan and sponge baths and that sort of thing. So if we look at the poll here, let's vote to see what we think Mrs. E might be suffering with. So are we looking at panic disorder, obsessive compulsive disorder, agoraphobia, or illness anxiety disorder? And I'll give folks a second to decide. All right, everybody make your choices. That you're not going to get graded on this, so don't worry about it. Don't take it too much to heart. Emily, do you want to share the results of the poll?
Yes, I will close the poll. So if you didn't get a chance to vote on this one, there are some more coming up.
We'll do another one. Think quickly on our feet here. Okay.
Everyone able to see it? Yeah.
Yeah, so we've got the majority of folks, 68% of folks voting for agoraphobia, and then kind of evenly split between the others. And the agoraphobia people win, right? So in this case, that's what we're looking at. Even though she may have some of those symptoms, like that fear of those things happening, right? Of, falling and dying and losing consciousness, right? She's not actually having panic attacks, okay? And, sometimes we may think about this as OCD because of some of these other symptoms. or illness anxiety, again, because she's worried about her own health. But in general, agoraphobia better describes this than any of those other three. Okay, let's take a look at another one. So Emily, if you want to launch case study 2 while I talk about it. So in this case, we've got a guy who's 20 years old, reports he feels depressed, experiencing a significant amount of stress about school, says, he's probably going to flunk out. He spends most of his day in his room playing video games. He has a hard time identifying anything that's enjoyable in a typical day for him. He rarely attends class. He's avoided reaching out to his teachers to try to salvage any of his grades this semester. He's always been shy and has always had, although he's always had a small and cohesive groups of friends from, elementary school and through high school. His stress and distress has gone up significantly since he began college. When he meets new people, he has a hard time concentrating on the interaction because he's busy worrying about what they're going to think of him, and he assumes that they're going to find him dumb or boring or think he's a loser. So what do we think Mike may be suffering with here? Major depressive disorder, social anxiety disorder, generalized anxiety disorder, or panic disorder? And again, I will give you guys just a brief moment or two to make your determinations. All right. Emily, do you want to share the results of those who have voted so far? Okay, so here we have the majority of people have voted for social anxiety disorder. And yeah, so, what we're seeing here, this idea of, worrying about what people are going to think of him, right, is a key feature of social anxiety disorder. So great job, everyone. I didn't even read the rest of his description to you guys. So you did good even without all the information. Let's do this one last one. Emily, if you want to launch case 3, there we go. So here we have Ryan, who is afraid of turning into somebody else, which means to him that if he comes into contact with someone he perceives as bad, that he's going to acquire those undesirable characteristics and he's going to lose his own essence. So there's one person in particular that Ryan really loathes. His name's Dante. And he thinks that Dante is a terrible person who doesn't care about others. So he avoids any place that Dante might be or might have been at any point. So at school, at the swimming pool, at the library. Not sure where Dante can be at all times, Ryan sometimes feels like he even has to undo Dante's bad influence even when he hasn't seen him. So for example, before he enters his room, he's got a cup by his door that he spits into to try to get rid of that essence that he leaves at the doorway and won't allow in his room. So what do we think Ryan might be suffering with? Obsessive compulsive disorder, generalized anxiety disorder, specific phobia, or somatic symptom disorder? We'll give people a few seconds. All right. Let's look at the results. Okay. So we have a little bit more of a split here. We still have the majority choosing OCD, but a goodly number of people chose specific phobia. I can see that, right? So certainly, Ryan is afraid of this one particular person, right? But with specific phobia, often we don't see that compulsive side of things, where the person feels like they have to do something to negate or neutralize the obsessive thought. And so here, you know, Ryan, this last part about spitting into the cup, that's a compulsion designed to address that obsession. And so it seems like obsessive compulsive disorder, OCD, would better fit here. Okay. Now, I know, you know, we kind of, there's some other slides I have about treatment. We're not going to have time to get to those. I want to, you know, be able to address, you know, some questions that people might have. So in the last 2 minutes, Emily, were there any questions that, that we can address?
There were a couple that came in. Have to scroll up at this moment to try and find them. One came in that asked if recurring dreams where a person feels paralyzed and cannot move considered panic attacks during sleep.
So a panic attack, those unexpected panic attacks that we were talking about, usually happen when the person wakes up and they are moving. So they're not like paralyzed or anything. But what I think you're referring to is sleep paralysis, where many people experience this sensation of, again, you know, they're having a nightmare or something, but they're, you know, maybe partially awake and they feel as if they cannot move. And they actually, it's actually a physiological thing, because the brain still has the motor centers shut off because you're sleeping. And so that's why you can't move. So those are a little bit different. The panic attacks occur when you're, you know, fully awake and, you know, sort of just starting to get up and get out of bed. Whereas the sleep paralysis is, you know, in more of a twilight kind of state that occurs. Any other questions?
There was one question. How do any of these disorders, anxiety disorders, pertain to children with autism?
So we know that individuals with or on the autism spectrum can experience these anxiety disorders. Often they are more difficult to diagnose because of communication difficulties or insight, but we definitely do see that you know, individuals on the autism spectrum can experience, you know, OCD or panic attacks, etc. So it's just sometimes a little bit trickier to diagnose, because we have to you know, sort of be aware of what their behaviors are and really kind of diagnose based off of what we can see, oftentimes because of the difficulty with verbalizing the cognitive symptoms. Okay. One more or?
Those were the only ones that came in through the chat. If anyone has a question they would like to unmute and ask in the last minute, you're more than welcome, invited to.
Okay. All right. Well, it has been fun to get to spend the last 3 hours with you all. I hope that it was useful. I hope that it was helpful. And like I said, you know, gave an introduction, the basics about the anxiety disorders. As I mentioned, you know, we're going to have sort of a second part of this that's going to be about treating, you know, how do we treat the anxiety disorder? So definitely, if you're interested, sign up for that as well. But thank you all so much for your attention and participation today.
Yes, thank you, Sandy, for leading this workshop, and everyone look out for that follow-up email. It'll have the recording and slides, as well as the information again about the CEUs if you're seeking those. All right, have a great afternoon, everyone. Thank you for joining us.
Thanks, everyone. Bye-bye.